Aloha, my name is Stephany Vaioleti. I'm the administrator at Kahuku Medical Center and wanted to thank you for attending this session. I hope all of you have found the conference as invigorating and as inspiring as I have thus far. Our topic today is overcoming challenges facing rural and neighbor island communities. Unlike any other state in the United States, Hawaii has unique access and resource distribution challenges due to our island geography. Rural hospitals and community health centers are finding ways to continue to meet their community's special needs in changing times. Hear how these organizations on Lanai, Kaua'i and Hawai'i Island are overcoming such challenges and transforming care in their own right. So our format today is going to be like the other sessions. We're going to have 3 presentations. The copies are available on the website, hawaiihealthcareproject.org. I have a couple questions for them, and then we'll take questions from the audience. We have a microphone right there. And then there'll be an online evaluation form that will be sent out shortly. So I want to introduce our speakers. Our first one is David Peters. He's the CEO of Ho'olahui, Hawaii. Mr. Peters has served for the past 15 years as CEO of Ho'olahui, Hawaii on the island of Kauai. Ho'olahui, Hawaii is a native Hawaiian healthcare system and a federally qualified health center. He serves as the current chair of the Kauai Regional Board for the Hawaii Health Systems Corporation. He has held various positions statewide to assure that the uninsured in Hawaii gain access to affordable quality health care. Mr. Peters has over 22 years administrative experience in the provision of health care to rural populations in Hawaii and on the mainland. Kristine McCoy. Dr. McCoy is a family physician responsible for the development of the Hawaii Island Family Medicine Residency Program, which will be graduating 4 family physicians per year. In addition, she administers the HHSC Primary Care Training Program, a collaborative effort of the University of Hawaii's 2 schools of nursing and College of Pharmacy, and Iola Lahui to train primary care teams. In addition to these organizations, medical students and residents from JABSOM also participate. Previously, Dr. McCoy practiced in rural northern New Mexico. She began her career with the U.S. Public Health Services Office of Disease Prevention and Health Promotion in Washington, D.C. And last but not least is Nick Hughey, who has direct oversight responsibilities for Kula Hospital and Clinic and Lanai Community Hospital. In addition, Mr. Hughey is responsible for post-acute strategic planning and partnering for the region. Prior to Mr. Hughey's current responsibilities, he was a hospital CEO for a regional healthcare system in Texas, Kula Hospital Administrator, and HHSC Maui Region Clinical Resource Director. Mr. Hughey is a registered nurse and holds a BS with an emphasis in healthcare administration from the University of St. Francis and an MBA healthcare management. So I'm going to turn the time over for David to start with his presentation.
Hey, it works. Thank you all very much for allowing me to come talk to you today a little bit about the model that we've chosen on Kauai to deal with some of the paucity of resources that we don't have. This is kind of how I feel sometimes, kind of out there by myself in the kai, trying to head my way forward. But fortunately, I have a couple of tools to uncork that cork and start working in a more collaborative model with other institutions and organizations on Kauai. So part of the focus of my presentation is really going to be on collaborative models rather than a competitive model that we're so used to hearing about. I thought this is appropriate for Thanksgiving. We need a social media strategy. You're an idiot. We need a survival strategy. Maybe the media strategy is part of the survival strategy, but it's just one part of it. We really are in a survival mode. Healthcare is changing. The resource pool is continuing to stay at the same rate while our costs go up. And so we have to do things maybe a little bit differently than what we've done in the past. And my focus on Kauai, since I've been there for 15 years, with my organization is really been focused on more collaborative models of service. But let me tell you a little bit about community health centers and the Native Hawaiian healthcare systems to give you a little bit more of a sense of who we are. So our ultimate goal is really to create an integrated continuum of care on Kauai. And in such, our own organization is the only organization in the entire world that is both a federally qualified health center and a Native Hawaiian healthcare system. So we've recognized early on that for everyone to be healthy, we have to take care of everyone on Kauai. And we may have to do that with different types of models, but it's very important that we do that. And we have to do that through collaboration. We have 3 major healthcare providers, institutions on our island. Hawaii Pacific Health has Wilcox Hospital, and HHSC has Kauai Veterans Memorial Hospital and Samuel Mahilona Hospital. We've been working collaboratively with all 3 organizations to try and improve the overall healthcare of Kauai. So some of the advantages that we have as a federally qualified health center is we really do have the primary care experience to low-income populations. We really understand how to manage that population, and we understand their needs. We have quality care as a cornerstone. It's not about making the money. For us, it's about the quality of care. We have a multidisciplinary integrated care, so we have medical, dental, behavioral health. We even have fitness, traditional healing services, and community-based healthcare education, which we think is vital and important. We also have care managers that help manage patients' care throughout the system and navigate them to where they need to be. And we have outreach and eligibility assistance to help those people enroll for those social health care needs that they also have coverage, food, housing, those kinds of things. As the Native Hawaiian healthcare system, we have people who are Native Hawaiian who have experience in working with Native Hawaiian populations. The Native Hawaiian healthcare system dollars are actually allow us to do a lot of preventative type of health service, which is something that we really are kind of bound not to be able to do with our community health center dollars. So it gives a little bit more focus on that. We also have experience in working with traditional healing services, and we have a very strong tie to that community and knowledge of those community needs. So our organization positions itself in 2001 to really start working on this more integrated system. We're trying currently with the other facilities to look at alignment of primary care on Kauai so that we're not duplicating efforts. We're co-located, our organization, within 2 of the hospitals, so our outpatient service are right there. So a patient has a one-stop shop. We're trying to create the referral patterns for appropriate care. As a health center, we have some safe harbor provisions that allow us to work with the anti-kickback statute. So we could get in-kind equipment or reduced rents, those kinds of things, because there's a safe harbor. And again, that one-stop shop concept is very important to our patient population. So some of the benefits that we have is we do have an increased revenue to the overall system because we do get what's called a cost-based reimbursement. But I think a lot of people mistake that for, oh, you get more money. But we provide more care. We have more wraparound services to help people get what they need. We're also working to avoid the unnecessary duplication of efforts in our community because we know that that really has a lot to do with cost. Oh, I got 5 minutes. Okay, cool. I keep going. Cost savings from quality-focused care. We're already starting to see some cost savings because we have a lot of preventative care that we're providing, so we're doing that upstream intervention that's so critical and important. The other thing that has helped us with our collaboration is we're trying not to duplicate recruitment efforts so we can actually get the right provider mix on Kauai and not have to continually compete for providers. And then the other thing that we're focused on immensely in my organization is really looking at patient satisfaction to try and make sure our patients are happy with the care that we're providing. So what are some of the requirements for the collaboration that we started in 2001? We all need to come together with an approach and a strategy prior to engaging. If you don't do that, you're going to fail. Parties need to see the benefit to the community and be willing to navigate through those turf issues between organizations. Those are really challenging issues, but if we build that trust, I think we can move forward and do that. We've had some success in that. And it takes planning, and the parties must remain flexible given the ever-changing environment that you and I all live in every day. I got this from the New Yorker magazine, and sometimes I think the collaborative process would work better without you. This is not the idea that we want to portray. We really need to start look at working more collaboratively together. And so this is going to take some high-level thinking. Patients have to be the center. Systems will only survive if they recognize that competition with scarce resources is unworkable. It's just not sustainable. On Kauai, we have 67,000 people. We can't continue to compete with one another. We're not going to be overproducing so that we make more money. Those days are long gone. And unfortunately, or fortunately, depending on your viewpoint, technology will drive the future, and we need to embrace it and utilize it in the best way possible that respects the human being focused in between. So I just want to say mahalo. Did I do good on the time? Oh, good. Thank you.
Good afternoon. So earlier today, Beth Giesting said that we don't train our future healthcare providers in teams. Well, my job this afternoon is to tell you that that's not true. So let me tell you a little bit about what we're doing in Hilo, which is intended to serve all of the neighbor islands. As I was introduced, I came here from northern New Mexico, and to me, Hilo's a metropolis. So for those of you who live on the neighbor islands in much smaller communities than Hilo, I really do understand the kinds of places where you live and work, and I understand the needs of your community. It's not possible to train doctors in the teeniest of our communities, at least not for the vast majority of their training, but it is possible for us to get them out to your communities and to train the right kinds of providers to come to your communities. So let me tell you a little bit about the HHSC Primary Care Training Program. And this training program is a little bit like herding cats, because although we call it the HHSC Primary Care Training Program, only one piece of it actually belongs to Hawaii Health Systems Corporation. The rest of it is really a collaborative effort among a bunch of educators in the state of Hawaii that have come together to make this happen. I think all of you know this, and I'm preaching to the choir, but this is the situation that we have in terms of physician shortage on our neighbor islands, and this was the update as of about a year ago. And if you look at this, Hawaii Island is generally considered the least well-resourced, although Lanai kind of beats it out by the statistics, but their statistics are a little bit challenging since the numbers are so small. And the same thing with Molokai as well. So we all know that our neighbor islands need more healthcare providers. This is what happens because we don't have those providers. Folks cannot get in to see a physician. And so when folks around the state were asked if they had this problem, this is the response rate of people around the state. So what happens when they can't get in to see a doctor? Well, in the survey, 23% of people who were surveyed reported that either they or a family member had to go to an emergency room because they couldn't just get in to see their regular doctor. In addition, we see a tremendous growth, at least on Hawaii Island, of urgent care. Both of these solutions are, one, much more expensive, and two, very disconnected from the main source of care where the providers really know the patient and can provide the highest quality care. And of course, there are plenty of people who go without care, delay care, and come in quite ill. This title is missing a few details. This is the age of our physicians. So if you look at the percentage of our physicians in the over 60 category, you can see that Hawaii is overrepresented in terms of aging physicians, and it's quite underrepresented in terms of younger physicians. As you can imagine, this is going to be a problem as our economy recovers and our physicians' 101Ks turn back into 401Ks and they decide that it's time to retire. The CEO of Hilo Medical Center was the one who asked the question today, what can we do to prevent our physicians from retiring? I'm not sure we got too great of an answer to that, but we definitely see that we have a problem now, and this problem is coming at us very, very quickly in terms of acceleration. On Hawaii Island, the physicians were surveyed in 2010, and this is what they said. 20% were planning to retire within 5 years, and 13% were planning to leave. This was 3 years ago, so this will be our reality in 2 years. We'll only have 68% of the physicians that we had in 2010. And this is the state's picture. This is the earlier version. There's an updated version from last year that shows the trend being not quite so severe, but again, a big discrepancy between the number of providers we need and the number that we believe that we're going to have. So what are we doing about this? This process really started 20 years ago, but it started more substantially again in about 2006. And it was a joint collaboration between Hilo Medical Center, the John A. Burns School of Medicine, and the community. And they came together to see if we could put together another place where physicians could be trained in the state, and particularly a place on the neighbor islands where they could learn to provide the kind of comprehensive care that's needed outside of an urban center. This has taken a little while, but it's come together with Jabson providing much of the technical assistance. We've had a clinic up in operation since 2009. We've had our faculty complete and on site since this summer in August, and we were just granted accreditation for a family medicine residency training program just last month. These are our partners. So our partners on the clinical side are Hilo Medical Center, of which part is the Hawaii Island Family Health Center, our clinic, and many, many physicians who are in private practice in the East Hawaii community. On the academic side, we have Jabson, the 2 UH schools of nursing, the UH College of Pharmacy, and Iola Lahui. Financially, our partners have been the East Hawaii Regional Board of Hawaii Health Systems Corporation, the federal government in terms of a $1 million startup grant, the Hawaii Department of Health, our local insurers, including notably United Healthcare coming to the plate this last year, and our local community, our Rotary clubs, our Lions clubs, individuals who write checks to make this happen. So this has been great because we've been financed through this academic year, but I just want to make everybody aware that that money will be gone by the time that those first physicians show up to train on July 1st. But here's what we're doing, and here's why we really need all of the help of all of you in the room to make sure that we can continue this forward and create an ongoing line item for this training program to keep it going. We are training as a team, just what Beth Giesting said we needed to do, but we weren't doing. And we're doing this in order to advance the patient-centered medical home model. And in our ideal world, these teams with enough team members can stretch one doctor to take care of 10,000 people. Now, a doctor costs $1 million just for their residency training alone. Add medical school to that. That's a good reason that you want to stretch us by adding a lot of team members. So if you look at the way that our program is structured for, we create a team that is really the equivalent of 4 doctors for 1.6. So it is a lot more efficient way of putting the care team together. And I know you've heard a lot more earlier today about why that's important. So I just want to close by reiterating that this is already going, but the essential and most expensive piece of it is the family medicine residency training program. There will be federal funding that's going to be forthcoming, but it takes several years to get that going. And so I really want to reach out to all of you in the neighbor island communities to let you know that this program is here to serve your needs. The next thing that we want to do is set up rural rotations on the other islands as well as the other parts of Hawaii Island to get our residents out into those communities so that they know where they can put down roots and they can practice. And they can bring with them the teams of pharmacists and advanced practice nurses and other nurses and behavioral health folks as well, so that we really can provide the types of care that everybody's been talking about today. Thank you.
Though Lanai is much smaller than the other facilities, I think you'll hear a lot of the more central themes, that you have to be strategic in what you do, you have to use the economies the best that you can, and you have to collaborate. So you'll hear a lot of that sort of central thing in my presentation. So the title is New Strategies to Meet Lanai's Unique Needs. So just to give you general information, because a lot of people, Lanai is a really small island and it's a little unique, and a lot of people have not actually had exposure to Lanai. And so one of the things that we're trying to do is just get more people on island, because I think it's it's something that you have to see, to really experience and to fully understand. And because it's not it's not a novelty. I mean, it's an island where people live, shop, breed, have kids, families, dreams, and all of that sort of stuff. So you get a better sense of it if you actually can come and see it. But as an example, I had it all set up through our Neighbor Island Advisory Committee through HAH for a whole group of leaders to come and visit Lanai through our Neighbor Island Committee. And so everybody was playing, everybody was to come. I was really excited that we were going to have everybody come get exposure to the island. And then about a month out, everybody started to try to get their travel plans together. And the reality was we couldn't get enough people there with the plane schedules and with everything to get everybody in and out. So we had to move the meeting to the island of Maui. So again, certainly we're working on that and we're excited about it. But that is part of the problem with Lanai, is you just don't get enough exposure to it to really fully appreciate it and understand its nuances. So just to give you general information about Lanai, it's an approximate population now here, it's about 3,100, so we're growing rapidly. It's a between 97 and 98% island is privately owned by a single landowner, who's Larry Ellison, Oracle. And the hospital is operated by Hawaii Health Systems Corporation. The primary care is provided by Lanai Community Health Center and FQHC, and Straub Clinic, HPH owns it. So you have three distinct entities providing care to about 3,100 people. And you have, and then you have a lot of different folks who are active in the community with different initiatives to provide a continuum of elder care services, including hospice. So there's just a lot going on with a lot of entities moving in a lot of different directions to provide care to a small number of people. So we're really working to try to create more synergies around that. Just so that you have a better understanding of the hospital itself there, we are a critical access hospital. We have 4 acute beds. We have 10 long-term care beds, which pretty much stay full. We provide the imaging and lab services for the island. We have a 24-hour, 7-day emergency room. One thing to note about that emergency room is, I mean, I've been in healthcare for 22 years, and I'll speak a little bit later in the slide, but I've never worked in an environment, because this is what happens is, the Straub Clinic is right next door, and if somebody can't get into an appointment, they just didn't make an appointment, or they just whatever, they want urgent care, or they can't get in because they stay pretty full, what they do is literally walk across the parking lot and go to the ER, and the same doctor that couldn't see them in the clinic, by EMTALA regulations, has to then walk across the street and see that same patient within a 30-minute time frame. So what happens is all the people who made their appointment, who did all this sort of stuff, are sort of delayed while the doctor has to go across the street. I mean, that's really how unique and one-off we are in that sense. Because I've never heard of that anywhere else in the world of healthcare. One of the things that we do at Lanai Community Hospital is we do as best as we can to create economy. So we do lease at a very lease space to public health. So they do have a public health nurse there, and we've expanded services with Liberty Dialysis in the back there. So we appreciate those guys, but they lease space from us as well, so that we are using that building to try to maximize the services. We've recently done about $2.3 million in renovations to our ER, lab, imaging, and a new waiting room. So we're trying to beef the place up, but doing the best we can. And we have about another $1 million in CIP already encumbered to do some photovoltaic and a new roof. So we appreciate that support. We do about, just to give you an idea of Lanai, just because a lot of people don't have exposure, we did about 1,150 ER visits. We did 57 acute days. That you can obviously read all the statistics, about 3,000 ICF patient days, and the imaging and the labs and the transfers. So generally, we transfer most of our patients. The vast majority of our patients actually go to Oahu versus Maui. But this is the bigger principle for Lanai, is the traditional healthcare business principles are not fully applicable due to the small population base and the inability to gain additional market share. So I always just say, I have a traditional formal education in healthcare economics and all this sort of stuff because I have a bachelor's undergrad in healthcare management and an MBA with an emphasis in healthcare management, and you get this book about all the economies and what you do and how you try to do market share and profitable service lines, and you do all of that. And essentially, you take that book and you throw it out the window, and because it's just truly not applicable. So what you have to do is you have to really think in a one-off manner, and you have to be creative, and you have to collaborate. And ultimately, there are no silver bullets, so we have to band together and be smart. This slide is a busy slide, but it really is the meat of it. And this is Lanais Challenges with the hospital, or what I believe. I mean, I don't speak for the island of Lanai. There's a lot of people who have varying opinions, so I want to make that clear, my opinion. But this is also the challenges that you see related to neighbor island or rural healthcare. Cash on hand versus net income. And that just correlates with the second bullet, is that operational capital is the most difficult in a small rural environment. What we do particularly good is we get large item ticket capital. Like I said, we've had like $3.3 million to invest in it. But as of today, I have $72,000 cash on hand from my operations, which is a little less than 2 weeks of cash. Because basically the cash that we create, because we don't have the economies to generate large amounts of revenue, so we essentially pay our payroll and we make our AP, and then we have a little bit of cash. So aside from large capital projects, we are having to make tough decisions about, do we buy this van, or do we get new dressers, or do we do all of this sort of stuff? And that's not unique to Lanai. That's pretty typical of a lot of your critical access hospitals in Hawaii. Is again, it's always the cash on hand. Cash is king in those small environments, and you're always consistently having to make tough choices. So you have to work to ensure the safety net viability and also attempt to meet the community's healthcare wants. So there's always this struggle about, you have to remain viable, but you also want to hear what the community wants. And at the same time, you have to educate the community on the resource realities in a rural healthcare environment. We cannot afford, without a subsidy, we cannot afford a CT or an MRI. We just flat cannot afford it. Because it's not even the equipment, it's the $1 million in upkeep every year. So we have to continually update. People say, why don't you have a CT or why don't you have an MRI? Well, we're working towards it, but ultimately at this time, we just we cannot afford it. So you have to be honest and realistic about that. Staffing is a challenge because you always have the skill mix and ancillary specialties. It's hard to find people who can do long-term care and emergency room nursing. That's just those skill mixes in today's market really don't exist, and so you have to be really creative with that. Housing, education, and the cost of living are a challenge. And again, this is for Lanai, but it's also for the neighbor islands. And so you have to be creative what you're going to do with housing, and you have to find people who have a desire, who want to live in the rural community. And then you need to assess new services and the impact to the overall healthcare delivery system. What we had on Lanai is after Mr. Ellison took over ownership, we had a lot of people who had some renewed interest in Lanai, and so we would have different entities who had expressed interest in coming into the community, which is good. That's exciting. But you also have to think that through, because if you add one entity, is it going to weaken the rest of the entities because you're going to pull volume from already where you don't have monies that exist. So you just have to think really strategic, and you can't knee-jerk, and you can't get overly excited, and you have to think about the healthcare system in totality. And so we're fortunate that we have people who are thinking like that. We know there's lack of redundancies. We have 2 doctors on island. Periodically, we have 1 doctor on island, and there have been times when doctors gotten sick, and we've had no doctors on the island. That's very rare. I don't want to overly not chicken little, but the reality is there's a lot of times that we have one doctor on the island, which means if something was to happen to that doctor, till we can get another doctor on the island, which could be ours, there is no doctor on the island. It's very unique. So we have to work to create more redundancies. And then you have just different, distinct providers for a small population base. So what we're trying to do, these are new strategies that we're working to do as the hospital, is we've engaged a full-time on-island administrative oversight. So we have somebody on the island who's responsible for the island, the hospital at all times on the island, which was a big step for us. We have greater participation in the community. We started running ads in the local paper, which is the thing you're supposed to do, which we weren't. So we're doing groups, we have health fairs, and we developed a hospital auxiliary, which we're very excited about. We're excited to say that the Palama Lanai is an active member, pioneer members of that, and other people from our community. So what we're trying to do with that auxiliary is help with those small operational capital needs, do special projects and initiatives. And we have our holiday. So if you happen to be on Lanai this Saturday and you want some baked goods, come to the park because our auxiliary is going to be out there. So we're excited about that. And then ultimately, you got to educate your stakeholders. We have regular meetings with Palama Lanai, state and local healthcare leaders, legislators to inform them of the challenges and to engage them to help with solutions. So we're just doing a lot more talking, and I feel real comfortable that I can pick up the phone and talk to these people, and so that we have an honest and open dialogue about what's happening. And we have to be honest and realistic. And I always talk about viability because we are a domino. We're a domino away from really being in trouble. We're about so we just have to, whatever we do, we have to be strategic because we just don't have the margin to screw up because we're talking about overall viability. So you got to strengthen your partnerships, establish regular meetings with other providers to discuss initiatives, leverage your existing economies as best as possible by having liberty and public health in our building. We're doing some CNA education in our building, again, trying to just use that building as best we can to create economies. We're in continuous communication with Palama Lanai. We have three of their executives here today in this session to ensure we're working together to prepare short, midterm, and long-term growth. And then effective, sustainable growth change cannot be achieved without effective and efficient healthcare as a strong element. So essentially what we always talk about is healthcare has to be in lockstep with the rest of the island. We can't get education or housing or anything ahead of it because if we don't have healthcare, it has to grow simultaneously. So we're working together and we're excited and we're doing some different initiatives and partnerships, and so we're working towards it, and thanks so much.
Okay, so I had a couple of questions. The first one is, I know we saw the numbers for Hawaii's physician shortage. Do you see the shortage in your own community, and how does it impact care?
So I showed those numbers, but I didn't really get to talk about them and how it affects us. So in Hilo, we have adjacent Puna, which is probably the fastest growing part of the state because it's one of the most affordable parts of the state. And my office happens to be located next door to one of the urgent cares that I referred to. And so what typically happens is you have a couple in their 50s, 60s, 70s that decide that Hawaii is the place that they want to retire to. And they find a cheap lot of land in Puna, and they buy that, and they build up a house. And they've been here maybe about 6 months, and then they figure out, oh my goodness, all my medications are running out that I got from my doctor on the mainland. What am I going to do? Well, they start calling around, and the reality is that there are 0 physicians with open practices outside of the community health center and our clinic. And since we've been pretty hard to find up until now, pretty much all they find is the community health center, and some people choose to go there and others don't. And so they go to the urgent care to get their high blood pressure medication refilled, and then the urgent care sends them next door to us. But it really, really is a problem. I mean, We're blessed with a very diverse patient base as a result of this. We've got, folks from the university and folks from the telescope and, folks who are living on the street and everybody in between, because there just is such a shortage of providers in East Hawaii at this time. And not only are those physicians that are in practice aging and having absolutely mature practices that really can't take on new patients, but those physicians don't have any means of going about replacing themselves. They're honestly just making ends meet for themselves, and they don't have the additional resources to bring in new partners to take over for them.
And I think on a bigger scale, what we see too is there's just lack of access to care. And so what we see a lot on Maui, and I think it shows it empirically, is that Hawaii as a state has one of the lowest per member per month Medicare beneficiary amounts that we spend. And that's not because everybody's in great health, it's because they're not getting access and they're not spending the money. So what we see a lot on Maui, instead of somebody getting ongoing diabetic care, they show up to get their hand cut off, which is ultimately makes it harder when you want to do demonstration projects for CMS, because if we create more access, we're probably going to create more cost. So it's so that's sort of what we're dealing with when we're trying to be creative in that respect.
Well, I think that Kauai is blessed in so many ways because we do have a little bit more access to care than maybe some other communities do. So I feel very fortunate to that. But one of the other things that we're doing, at least in my organization, is really trying to look at not just physicians, but also nurse practitioners, physician assistants, and trying to really look at the expansion of care, because not everybody has to have a physician visit. So but there has to be education in the community about what that means too, because we have people in the community that don't understand that difference. Some do, some don't. So that's one thing that I think we're working on, trying to get more of that extended care available to us. And I think the other thing is that we see more of the revolving door issue on Kauai, which is we get people in, they get really excited, they want to be there, oh, this is a beautiful place, and oh my gosh, it's wonderful, and then the cost of living, the school systems, the fact that we don't have as much shopping. We've had people leave because of that. So they're not used to living in that rural community, and so they have a different opinion about what it is. But I think on Kauai we've been very fortunate. But we also have some major healthcare institutions that really have a very active recruiting program. So I think that's been helpful to us. But I think in the future, as we continue to grow, the problems is going to get worse.
Thank you. So we talk a lot about collaboration and partnerships. So if you don't know, there's 9 critical access hospitals throughout the state of Hawaii, and we get together quarterly to talk about key performance indicators and different strategies and challenges that we've been working on within our areas. So I love David's cartoon about the collaborative process, but with the limited healthcare resources on the neighbor islands and the need to collaborate, how do you go about doing so when not everyone is in agreement? So please share some good collaboration and challenges with collaboration.
Well, the strategy that I try to use that doesn't work all the time, but that I try to use is always try to put the patient or the community in the center and then work around from that. That seems to be the most effective ability. Sometimes some folks you just can't work with, and you just have to, reality. But I think the best you can do is always start by putting the patient in the center, and I think we had some measure of success with that. So I think that's a good way to do it.
So in terms of the general medical community, I think one of the things that's really helped Hawai'i Island is that we were the recipients of the Beacon Project grant. And although that didn't quite come to fruition the way that it was intended to, it got people talking a lot about collaboration. And it got people a lot less worried about sharing information and understanding the proper systems that had to be put into place to share information effectively. We also have, for better or for worse, a growing system of hospital-based clinics that are all on the same electronic medical record, which is very helpful, and increasingly bits and pieces of other electronic data sharing through the state HIE and other means as well. So I think, we're conceptually a little bit ahead in terms of people having spent so much time talking together as part of the Beacon Project, even though we don't have the products of that we would want in terms of a health information exchange. We do have a lot more around care management and care coordination. From my perspective, of course, the other piece around collaboration is the educational collaboration. And I think a lot of what we're doing in our primary care training program is working beautifully in terms of having our students from the UH College of Pharmacy, having our students from the 2 schools of nursing, having our postdoctoral fellows and predoctoral interns from Yola Lahui, having our medical students from JABSOM and our residents from JABSOM, and soon to be our own residents. And it's working really well in the clinical training. People are working together, everybody's working with the other disciplines, everybody's seeing the patients together, and I think the patients are really benefiting from that level of collaboration. What we haven't been able to do quite yet is the educational collaboration, where we're able to get all of our learners together at the same time to do the lectures and workshops and case-based presentations. So for us, that's really the next challenge that's coming.
I think one of the difficulties in collaboration, the impediment, is really basically fear. People have what I call the whiffums and the wimbies, which is what's in it for me and what's in my best interest. And if we can address those 2 things with people and put them at ease a little bit, that there's going to be some win and some loss, but it's not going to be a total loss for you, that there are some wins there. If we can work on that sort of mind frame to come together, again, I think Nick's community focus is something I think about a lot too, but I think if people knew that we're not going to go around and get rid of an organization and all kinds of people are going to lose their jobs. And, if we can kind of come to some win-win situations and start building that trust, I think the trust thing, which was talked about earlier today, is really important. You have to build that trust in order to be able to move forward. So start with some small collaborations and move forward. That's my recommendation.
Thank you. Okay, we have 10 minutes for questions. So if any of you...
Could I add one thing on that?
yeah,
I do think it's important. When you're looking at the systemic change, you have to be willing to be patient. I think that's a big learning that we've had. We started a healthcare collaborative on Maui with all the providers come together every other week, and we've been in it almost a year. And we're getting meetings with people, and we're doing the right things. And then we had HPH come and talk to us about, because we're looking at, population management, how we're going to do ACO. We've not accomplished it, but we've built the trust. But when they came and visited, they said it took them 3 years of just meeting before they were able to do it. So I just think that when you're looking at big, broad, systemic stuff, you gotta be willing to be patient and stick it out. I think that's something.
The marathon. Okay. If any of you have questions, if you could please use the microphone so that everyone could hear, and I know it's being videotaped as well.
But it's too far.
Oh, it's,
Well, come up here and use this one then, Kim.
And I have a mouthful, so I have 3 quick questions, and I speak quickly, so if I may. Number 1, of the retirees, of the percentage of the over 60 physicians that we're anticipating are retiring, how many of those do you think, and perhaps Dr. Whitney might have the best answer, but how many of those are snowbird doctors, those that came here in their retirement years and got a Hawaii medical license? Because I think that might skew the numbers. The other 2 questions I have are, they're mostly about Dr. McCoy's program, but as you develop the training, the cross-disciplinary training program, are you looking at competencies? I know you're looking at cross-disciplines, but are you looking at, like, in order to serve the community, that you need to have somebody that's trained in ER, somebody in long-term care, which I think you already mentioned, somebody in OB perhaps? Are you actually looking at skill sets and competencies versus disciplines? And the third question is, in the recruitment process, the homegrown, how are you addressing the grow your own health professionals that then can go and serve their own communities?
So one of the beauties of the work that Dr. Withy is doing is that she actually literally calls all the physician practices and asks how many hours per week they see patients. And so she's weeded out exactly those people that you're talking about. Unfortunately, the same thing hasn't been done for the scoring system that's used to create the health professional shortage areas. And so we have quite a few places in the state that don't qualify as HPSAs because those snowbird doctors are being counted. But in her work, she's actually pulled those physicians out. So I really wish that her database could be shared. And I know she's working on it, but it's a challenge. So really that the numbers are of the actual practicing physicians here in the state, which is pretty frightening. In terms of our training program, you asked about the skill set that's needed. Well, I think the decision to train family doctors as opposed to internists or anybody else precedes me by a long shot. But I think it actually fulfills that need. I deliver babies. I go to people's homes and do home visits. I go to the nursing home and take care of people in the nursing home. I go into the ICU and take care of people in the ICU. I really am that old-fashioned doc that's pretty much everywhere. And so, not that everyone will be exactly like me, but the intent is to train people like me who are the pluripotent stem cells, I guess, of medicine. And they may change what they do because their community doesn't need them to deliver babies, or their community doesn't need them to work in the ICU, and they can give up those skills. But the folks that come out of our training program are going to have that broad skill base. And of course, one of the challenges in putting the training program together was to find a whole bunch of other doctors like me who still have that broad skill set so that we could be the trainers. And there can only be so many of us. We don't have a whole lot of people to draw on. So that's really what our intent is in terms of creating the folks that can then adapt to whatever their community needs. If they need to work in HANA and be able to really run the emergency room and the clinic simultaneously, that's something that they should be competent to do. The third point I've just forgotten. Grow your own. So this, of course, is the challenge that they're in right now. And the Hawaii Herald Tribune did a nice article on Saturday about our recruitment process. I think this year for us is a challenge because we're jumping into the recruiting process of medical students a little bit late in the game. But we do have folks who are from Hawaii who have applied to our program, and we hope that all of them will end up being in our program if they meet the rest of our criteria once we've interviewed them. I'm not sure that we will have a complete set of Hawaii homegrown folks this first year, but I really feel pretty confident that in the years going forward that we will. We work with high school students, we work with college students and pre-med students and medical students. There's really a lot of outreach both by the AHEC and by our program as well to reach into the local communities and to bring up people so that we can replace ourselves with homegrown folks.
I have a question a little bit related to that. Have any of you thought about expansion and partnerships and collaborations with the Department of Education? There are some high schools that are starting health academies, and there are some situations, as in Kahuku, where they have actually they have the first school health center on the campus. And I'm wondering if there's any thinking or hopes, ideas, dreams around some of those issues.
Well, I can tell you for my organization on Kauai, we're in the Hawaiian immersion schools. We already provide health education in there. We're also doing PE on the weeks that it's not provided. So we have a curriculum that we've developed and are in there. Unfortunately, I had a Native Hawaiian education grant for about 6 years, and we developed a whole training program to recruit young kids starting in the elementary years to health professions, but UH seemed to suck up all that money, and we didn't get funded after that period. So unfortunately, we have a model that's sitting on the shelf ready to go. We were even doing tutoring in math, science, and English in the schools to get kids prepared, since those were the major impediments to them moving forward. So we started in the grade school component. So we're very open to working and continuing that. We just don't have the resources to go in a much larger group.
So I recently took the LPN that I work with most closely, and the two of us went to the career day at the Kamehameha schools in East Hawaii. And it was incredibly gratifying. I mean, these kids were so motivated, and they had very diverse interests. Some of them were interested in psychology, and some were interested in physical therapy or occupational therapy. And the vast majority of them were from their health academy, just as you said. So I think that this is an opportunity that we have to do more with them. I mean, we just started by reaching out to them during their career day. I know that those kids are invited to come to some of the workshops that we have largely through the AHEC at the hospital. And on the Kona side in particular, I know that this has really, really taken off, and the community has embraced it in terms of really bringing in these high school kids and getting them exposed to the diversity of necessary health professions.
I believe we're out of time, but I just wanted to share that we had at Kahuku High School, this last year for the 7th and 8th graders, they put on a homegrown afternoon. So they had a bunch of professionals that just were from our community. So I definitely believe that that is one of the ways to help our rural communities, is if we do grow our own. So I want to thank our panelists for the wonderful information that they shared, and for all of you attending. We're going to have a 20-minute break, so feel free to walk around and look at the exhibits, and we'll be reconvening in 20 minutes in the ballroom again. Thank you.
Oh my God.